Hey, Joe 200. It's me, Julia Walsh and John Walsh, and we're here to talk about Module 5. This week we're talking about cancer, and for the discussion we're talking about grief and loss and death. So it is what it is. Not everybody's favorite subject. Yeah. I am an expert on cancer because I'm a cancer patient. I'm in treatment right now. I was diagnosed in 2013. So I have 11 years of cancer patient experience. And as part of that process, I've kind of studied the field and have a passion for it. So that I always ask John, let me jump into the cancer lecture video.
And you can just see her as well for the 3 law lectures that are at the end. Now, all this is really useful stuff. And so in part of her history, she did a clinical trial for 3 years at UC San Diego Moores Cancer Center. That was like almost 7.5.
2016 to 2019.
2016 to 2019. And she had pretty good remission, but not 100%. And we were actually in Costa Rica last year, and she was starting to feel a little crappy. And then we came back and
there's a fly.
There's a fly. Yeah, by the way, we're in the jungle down here. So we might get some geckos. There it is again. So
sorry.
Yeah. So I don't know what to say, but it is what it is. So she came out of remission then, and there he is over there on the window, and so she's back into treatment. She's actually taking some of the targeted therapies that she might talk about today, as we talk down here in the jungle. So it is what it is. Okay, so all right. So we're going to go straight into Module 4. Yeah, as you know,
Module 5.
Module 5, sorry. We can go through content, okay? And I showed you last time you can use the widget, okay? So we can scroll down here and find, there it is, cancer. So I gave you some concepts in the biology of aging about mutations and things like that. And then when it would take this concept that with aging, we know what the #1 risk factor for getting cancer is? Age. #1. Yes, there's some childhood cancers, but 99% are age-related, and it's because of the biological mechanism we talk about, where you just don't have the opportunity to get in there and repair genes, and they go south, and then you get cancer. All right, so we're going to go into cancers module, okay? All righty. So Julie's found all these. She's responsible for doing all of Bright Space, and applaud her. This is going to be a mess next semester.
Sorry, he has a fly.
I have a fly too. Oh, you wouldn't believe the bugs. You wouldn't. But fly is a big deal. Yeah, it's all good.
Okay.
He's on my ear. Okay, there we go.
So let's go into the readings, and yes. So I want to talk good news and bad news. The bad news is that probably 1 in 2 or 1 in 3 people will get cancer in their lifetime. As John mentioned, the good news is it probably isn't going to happen to you until you're much, much older. The even better news is that we're seeing very rapid advances in cancer treatments right now. So cancers that were very difficult to treat, like metastatic melanoma or metastatic lung cancer, are now proving to be vulnerable to these new targeted therapies that are being developed. So we're seeing better outcomes. So you may have a relative who gets diagnosed with something that would have been a death sentence 5 years ago, but now with new medications, they might do very well and have a really good life expectancy or even a normal life expectancy.
So she's doing targeted therapy right now, and she takes 4 pills a day. All right, so it's not chemo. And just, it may be a topic that she talks about. Things are out of control. Each pill is $100. That's $400 a day. That comes out to about 120 grand a year. But just that part, she had another part. You know what? It's starting to get hot in here. That's what happens in the tropics. I'll let you keep talking. I'm going to cool it down.
Okay, so let me take over. Yeah, so I do want people, if you experience a cancer diagnosis in your family with your loved ones, don't panic. My recommendation as a patient who's navigated the system is get to the best doctor you can for your cancer. That's usually going to be at an academic medical center like Keck USC, like UCSD, UCLA if you're in the Southern California area, City of Hope. Get to the best academic medical center that you can get to. However, if you are a patient that is living in a rural area or in a part of the country that doesn't have access to that type of care, there are still ways that you can navigate the system by joining patient support groups, and getting access to good information from reliable sources like the National Cancer Institute, the NCI, like the American Cancer Society. And every diagnosis basically has their own nonprofit that creates information and puts out information. Mine is the CLL Society or the Leukemia and Lymphoma Society. So you can learn a lot from these patient groups that are out there. So it's very important. The mantra is smart patients get better care, educated patients get better care. So
we got a nasty flight.
You can do a lot to help your family members if they are diagnosed with cancer.
CLL, she said, is that her kind of cancer is called chronic lymphocytic leukemia. Okay.
Yes.
Awesome.
So one of the things that we do is in this course is we look at cancer statistics. When you look at cancer statistics, you're looking backwards.
I'll get rid of the flies.
So some of those numbers are reflecting older treatment. So if you look backwards, you're looking at people that were diagnosed when only chemotherapy was available, when they didn't have the more modern targeted or immunotherapies. So when you look backwards, the statistics are not going to be as good in terms of survival and prognosis as they would be if you're diagnosed today. So just always keep that in mind when you look at statistics. And I always tell newly diagnosed patients, if you Google what's my prognosis, you're probably going to see some bad information. When I was diagnosed, my prognosis was 5 years. That was 2013. So am I dead? No, I'm not. I'm doing fine. I still work full time. I do everything I always did. So do not panic. We want to talk about what the data looks like. So when we talk about mortality or incidence rates, we're talking, it's normalized per 100,000 people. And that allows us to compare the data between men and women, between white, Black, Hispanic, Asian American, American Indian. So we can compare all these different groups and see what's happening in different groups. Children and young, adolescents and young adults versus older people. So the good news when we look at all this data, a report should be coming out every year. It hasn't been coming out every year from the National Cancer Institute. So the most recent data that we have is this 2022 report. I'm hoping a new report comes out soon. What we're seeing is...
And the 2022 report looks backwards, so they have data up to 2019. Yeah. That's how it works.
Lung cancer and melanoma deaths are decreasing the most. There was, we have something where we call low-hanging fruit. We had these lung cancer and melanoma cases with very, very dismal prognoses. My aunt was diagnosed with lung cancer about 15 years ago. She survived 2 months.
Got him.
John's on the hunt. So anyway.
There's a death rate amongst flies around here too.
With these new drugs, people with lung cancer and melanoma are doing much, much better. The other thing that we see is that the cancer death rates for children and adolescents, young adults, has also declined, both for AYAs or adolescents, young adults, and also for children. We see a high participation rate in clinical trials for children who are diagnosed with cancer. We'd like to see a higher participation rate in clinical trials for adults. The only way we advance the science and the only way we advance these medications that can be approved by the FDA is for people to participate in clinical trials. So I participated in 3 or 4 different types of studies. One was a treatment study. Sometimes my doctor says, hey, can we take some tubes of blood? They maintain a tissue bank of people with leukemia, and anyone worldwide can request my blood if they want to study, hey, why does this woman I was diagnosed at age 50, female, for a diagnosis that typically happens to men who are 72. So, you contribute to the data. A lot of times we have students that say, I'm going to go up a tiny bit. Okay. A lot of times we have students who say, enough with the bad news. Can you give me some good news? The good news is that we pretty much know what we can do to prevent cancer or to mitigate your risk once you are diagnosed with cancer of relapse. So don't smoke. Cigarettes, I would include vaping. I would probably include cannabis. Exercise, regular exercise is important. eating a healthy diet, not the American diet, that's not healthy. Eating basically a Mediterranean, mostly plant-based diet is good.
As best you can.
Okay, you keep going.
I'm sorry, but
we're going to start bickering.
No, it's all good. But this is looking at the proportion of cancer deaths attributed to cigarette smoking.
Yeah.
And this is people that are 30 years and over. And if we get down here on the scale, it shows you that 80%, for example, of cigarette cases and deaths are because of cigarettes. And that's no big shocker. Okay.
Moderate alcohol consumption. 1 drink a day for women, 2 drinks a day for men. It'd be better if you did less than that. Limit your sun exposure, wear sunscreen. And it doesn't matter if you're white or black, wear sunscreen. We see, unfortunately, more melanoma cases diagnosed later in people with darker skin. So you can do a lot to modify your risk. Smoking is very, very clearly linked to cancer, not just lung cancer, all different types of cancer, oral cancers, bladder cancer,
esophageal right here,
cancer, 50%. Cervical cancer, kidney cancer. My dad was a lifelong heavy smoker. He was also overweight. Those are 2 risk factors for cancer. First he had kidney cancer, then he had bladder cancer, then he had lung cancer.
And it's no big surprise to you. The carcinogens are going bam, hitting the lungs, and bam, hitting you right here in the larynx. The esophagus is just downstream as you swallow. Okay.
Yeah.
However, it gets into your blood. Okay.
Yeah. Colorectal cancer, stomach cancer. We do not want, if we can, to have this risk factor. Now, what happens if you're a smoker and you're like, man, I've tried to quit and I haven't. If you have one risk factor, look at the other risk factors. So if you're a smoker, don't drink. If you drink alcohol regularly, then don't smoke. Eat healthier food. Get exercise.
Did you say exercise?
Yes.
There you go.
So exercise has been shown to not only reduce the risk of certain cancers like breast, colorectal, and endometrial cancer, but for the studies that are starting to come out show that for women who have been diagnosed and treated for breast cancer, if they exercise, their risk of relapse goes down. So exercise, healthy diet helps you control your risk of relapse in certain cases.
And it goes back to the prior lecture in the biology of aging, okay? So when you exercise, okay, your body goes into repair mode, okay? It just goes to a different section of your DNA. It turns on the genes that say, okay, here's the proteins, and these proteins go around, and they get rid of the mutations in your breast tissue, your mutations, say, in your colon, boom, 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 exercise works. And by limiting your diet, like Julie said, again, you're turning on genes, turning off genes that allow you to repair the damage.
And exercise also boosts your immune system. So if the cancer starts to come back, you have your immune system conducting surveillance and saying, oh, that cell shouldn't be here. I'm gonna target it and I'm gonna kill it.
And how does it turn it on? It turns on the right genes, which makes the right proteins to make the immune system good. All right. So you talked about alcohol.
Alcohol is also a risk factor for a lot of different cancers: colon cancer, rectal cancer, female breast cancer. So if you're in college and you're drinking probably more than usual, don't worry, when you get out and have to get a job, you're probably not going to be able to drink as much. But again,
it's your rite of passage. I did it.
Some alcohol use over time, not just the 3 or 4 years that you're in college, but alcohol use for 10 years, 20 years is going to contribute to your cancer risk. So when we look at new cancer cases, some of the bad news is that we're seeing an increase in GI cancers among younger adults. And this is a little bit puzzling. I'm seeing a lot of research coming out in this area, and they're saying, hey, we kind of thought it was because of alcohol use and obesity and lack of exercise, but we're seeing these young, fit adults coming up with GI cancer. So I think that's something, it could be processed food. We don't really know yet. So that's an area where we're going to see a lot of research and attention focused because we don't want our young people to get cancer. I want to talk about these trend bars. The red bars mean increase, the blue bars mean decrease. And the first one is rates of new cancer cases, again, normalized by 100,000 people, and looking at change over time. Sorry, this is one of the weird things that happened when we copied the course over to Brightspace. The figures got small, so I'm going to have to fix this. But we had to start somewhere.
You can do what I just did. See, you just go into your computer.
I was complaining to John. I probably spent 100 hours trying to get GERO 200 ready, and then there's still stuff that's screwed up.
Appreciate what you're getting this summer. Just wait for the fall chaos.
No, it's not going to be chaos. Just take our classes.
Yeah.
So anyway, so we can see these trends in rates of new cancer cases. So women are seeing an increase in melanoma, skin cancer. Men are seeing an increase in prostate cancer. We don't really know why. These trends change from year to year. The good news is that we're seeing less lung cancer, so probably less smoking, less occupational exposure for men, less thyroid cancer for women. I don't know. I don't have an explanation for that. But it is very interesting to watch the numbers go up and down.
And the way you figure this out, and a lot of you guys may become part of this, you become a sleuth, and that sleuth is called an epidemiologist who gets a job with the Center for Disease Control or just a local agency in the state of California, even your community, and they look for changes, transitions, and then you go then and say, what is different about these people during their lives that they had an exposure to something that increased the likelihood, because these are all environmental, believe me, it's all environmental interacting with genes. So that's how you figure that out. Before Center for Disease Control, what's another one? I'm having a senior
National Cancer Institute?
Yeah, something like that. These are all jobs that you could get.
Yeah.
Okay.
Right. Now, when we look at death rates reflect a couple different things. They reflect how many cases we have. You're going to have more deaths if you have more cases, where it's going to reflect perhaps cancers that are resistant to treatment, that are hard to treat, and it'll reflect environmental causes, lifestyle causes, things like that. So one of the things, of course, that public health people do is we want to target things that are preventable: excess weight, alcohol use, HPV infection.
And simple vaccination that all you guys should have got before you went to college.
This is where I give my commercial that I give every year to get the HPV vaccine. The CDC has approved HPV vaccines for people up to, I think, 26 years old. And if you're between 26 and say 44, you can talk to your doctor. It's a very simple series of, I think, 2 or 3 shots. Both of my sons were vaccinated. And to be quite honest with my older son, who's 28, when I chose to have him vaccinated, it was before we really had a lot of data. But I thought, you know what? If we can prevent his future sex partners from getting HPV, then that's a win. And then it turned out later on, the data came out that men were getting cancers related to HPV as well, particularly oral cancer.
I have a good friend who got throat cancer, is what it is, and then, I mean, it's a small circle, and then our niece,
two of our nieces,
got
at a young age, in their 20s, got an HPV-related cervical cancer. And realistically, in the world, by the time you're in your probably 30s, 50% of the population has been infected with HPV. So it's really common. It doesn't mean that you're promiscuous or you're a bad person or anything like that.
It's just life.
So anyway, remember, we have these preventable things. Hepatitis C infection. If you have Hep C and it's not treated, that can lead to liver cancer.
The virus, in terms of what causes mutations, there's cigarette smoke, there's smog, there's exposure to metals, but there's also viruses. Viruses will insert a little funky piece of their genetics into your DNA, and then boom, you can get cancer from that.
So when we look at our death rates, we definitely see the results of really great developments in treatment. So for both men and women, we're seeing a decrease in cancer death rates for lung and for melanoma because of these new checkpoint inhibitors that are now widely prescribed in the marketplace that have been very, very highly effective against those particular cancers. And the data doesn't even reflect yet, but it will in a few years, even more revolutionary treatments that are now being tried on very hard to treat cancers like brain tumors, called CAR T, where we take our own immune cells we modify them, we put them back in the body, and they go after, they just attack that tumor and beat it down. So in the next 5 years, I think we're going to see some pretty dramatic changes in the death rates.
Well, it takes about $500,000 to do that too.
Yes, but, okay. So my argument to the insurance companies, like for someone like me, you can treat me with this $500,000 treatment, or you can put me on an oral medication that costs $150,000 a year that may have side effects where I'm in and out of the hospital. And at the end of 3 years, you will have spent $500,000 anyway. So,
yeah. She wrote a letter to President Obama when he was president way back when, and he talked about her in his speech about a month later. It was awesome.
My one claim to fame.
Oh, it was awesome, man. Okay.
So anyway, I also want to talk about screening. So we find cancer by screening, by you go to the doctor, you get a pap smear. You go to the doctor because you may have symptoms and you get a chest x-ray or you get a CT scan. For men, you go to the doctor when you're John's age and you get a PSA blood test. So we've got blood tests, we've got imaging like
PSA is prostate specific antigen. It's a little protein that just takes off my cancerous prostate and goes poop into the blood, and then they can find it.
So we have a lot of screening methods. I get colonoscopies every 3 years because I'm higher risk, and you know it is what it is.
I woke up doing mine.
Yes. Is it my favorite thing to do? Probably not, but it's not the worst thing that ever happened either. And I really don't want to have advanced colon cancer.
No.
So we have all these really great screening programs that we need to get people motivated to get the screening exams, particularly post-COVID, post-pandemic, where a lot of people got out of the habit of going to get their mammograms, going to get their colonoscopies, going to the doctor at all. So we're expecting to see, unfortunately, a negative impact on COVID cases, on cancer cases and cancer deaths from the pandemic, from people skipping those important screenings, particularly in colorectal, colonoscopies, breast cancers, mammograms. And so this will carry forward.
There's a monkey on our roof, by the way.
There's a monkey hopping up and down on our roof. I love it here. I love the monkeys. Anyway, so going forward in the next 10 years, we're going to have these excess deaths. Why? Because when you catch breast cancer earlier, when you catch colorectal cancer earlier, you have more treatment options. And so you might be able to catch it, treat it, nip it in the bud, and it may not come back.
There it is, prevention, diagnose, treatment, okay? Boom, okay. But if you don't do it, then you get increased mortality if you skip these right here.
So ask your moms and dads and aunts and uncles and grandparents, have you had your mammograms? Have you had colonoscopies?
If it doesn't feel right, it's because it's not right, and just don't second guess yourself. Get out there and get it checked. We have the best medical care in the world. Believe me, down in Costa Rica, you get a real feel for that. So.
Okay, go down.
Right, it's kind of jamming here.
It's frozen.
That's okay.
Okay. Now I want to talk more bad news, where I think we have a lot of room to improve, and there is a lot of attention being paid by the federal government right now on what we call cancer inequity. So we look at cancer incidence and death rates per 100,000 cases, and we look both by sex and by race and ethnicity.
You look at the rate here is more definitely in Black people. You see right here. Then what jumps out at you right here is the death rate is a lot more than you see here. Why is that happening? That is inequity. That's not fair.
And there's a lot of possible explanations for that. When we look at the incidence rates, white people have the highest incidence rate. Is it because they have better access to health care? Are they more likely to get screened? Black people are next. American Indians, American Indian and Alaskan Natives are next.
Again, it's screening. Is what it is.
Asian Pacific Islanders are the lowest. Hispanics are next lowest. Some of that is what we eat. Some of that is access to health care. Some of that is occupational exposure. So there's a lot of different things. Some of that is trust in the medical system. A lot of different things.
And then you see here that again, you see the disparities and equities based on race, but you look at males and females, and what jumps out at you is you can see in terms of death rate, women are doing better than men, and that's because men can be dopes and they don't go see the doctor. Women see the doctor. At the very least, you have a pretty regular relationship with your gynecologist, and just by talking to her, you're going to find things oftentimes.
Yeah. So when we look at the death rate, that's where we see this, what we call cancer inequity. So the highest death rate is among non-Hispanic Blacks, and followed closely behind by American Indian, Alaskan Natives. And that's true for men
and women.
And for women. So we've got to figure out, one of the problems is a lack of participation in clinical trials. So if you look at a disease like multiple myeloma that is more predominant among Black Americans, we're using drugs that are tested in white people. Do they work as well? Do we have the right dose? Are we targeting the right approach? We don't know because we don't have the data. So, and a lot of it is, access to healthcare. So there are a lot of nonprofits out there that will provide financial support for cancer patients, but the system is hard to navigate. And, I've said to John last summer when I was really, really sick and I was trying to get on the cancer drug that I've been on now for 10 months, getting the approval from my insurance and getting the drug shipped out to me.
It was retarded.
I'm an attorney, I'm a college professor, I teach about health insurance. And I would have to sit on the phone for literally 3 hours on a Monday afternoon. So luckily I work at USC, I'm a teacher, I have 3 hours in the afternoon. But if I worked at McDonald's or Starbucks, I can't just say to my boss, hey, I'll be back in 3 hours. I'm going to be on the phone trying to work out.
People see these prices too, and they're like, I'm not going to get treated.
Yeah.
I don't have good enough insurance. I don't have any insurance. And then the other thing that people in the know what to do, but people that have not been exposed to it, is that drug companies will oftentimes help you based on your income. They have patient assistance programs.
So my dad had lung cancer, and part of his symptoms was a very low platelet rate, which makes you at very high risk for falling, hitting your head, and bleeding to death. So I was able to get him a drug that was going to cost $6,000 a month for free. But it took me time sitting on the phone, filling out forms, coordinating with the doctor, coordinating with the drug company, coordinating with the insurance company. So what you can do as educated people is you can be that advocate that can help your family members with cancer navigate the system.
Just realize that there are patient assistance programs with Abbott Labs, with Pfizer, all these different, you don't ask, you don't get.
Yeah. So anyway, it's a rough system out there. Yeah. Okay. My commercial for HPV, if someone had said to me, I was diagnosed in 2013, right. If someone had said to me in 2013, hey, we have a shot that will keep you from getting cancer, I would have
blow it up even more.
I would have said, hell yes.
Right.
And what we're seeing now with the statistics now that HPV vaccines have been rolled out, we're seeing in countries like Australia, they're ahead of us. We're seeing dramatic drops. They expect their cervical cancer rate to go almost to zero in a few years.
Transient cervical cancer,
and these are,
here comes
the rain is about to start.
It rains all the time in Costa Rica.
This is the data from the U.S.
Black, Hispanic.
We are again seeing across races and ethnicities a drop in cervical cancer incidence rates.
That. See, it drops off right there. Okay, bam, bam. Okay, what's going on here? Education. People buy into getting vaccinated. You know what's going to happen because of political infighting about vaccinations. I anticipate things are going to come right back up here.
Right? Well, anyway, and to make our story even happier, under the Affordable Care Act, your insurance has to cover your vaccines, so it's free. Okay, so you can go roll down to CVS or roll into the USC pharmacy and get these vaccines.
The Affordable Care Act. Here, do you want to put that on or not? Let's just do it.
Come on.
Here, watch.
John loves this.
All right, I gotta just find it. All right, patient with me as I scroll here.
Just take a break.
I do think I have it somewhere. There it is. Boom. All right.
That's funny. You watch it so often.
I do.
It's in your frequent face.
It has to be.
There he is. Okay.
Well, thanks to Monica. Thanks to everybody standing behind me.
Hold on a sec. We're going to get it out. Get this out of the way. He's just. We're not going to thwart him.
because for
right.
all the day-to-day fights.
We're going to get all the way out here. You got to get to the key moment.
I think it's like 4 minutes.
Yeah, it is. Okay, ready? All right, come on. It's going to go.
People who are here today, and the people that they represent all across the country whose lives have been changed for the better by the Affordable Care Act. You know, the other day I got a letter from Julia Walsh in California. Earlier this year, Julia was diagnosed with leukemia and lymphoma. I have a lot of things to worry about, she wrote. But thanks to the Affordable Care Act, there are lots of things I do not have to worry about, like whether there will be a lifetime cap on benefits or whether my treatment will bankrupt my family. And I can't begin to tell you how much that peace of mind means. That's what the Affordable Care Act means to Julia. She already had insurance, by the way, but because this law banned lifetime limits on the care you or your family can receive, she's never going to have to choose between providing for her kids or getting herself well. She can do both.
Now, too often we hear all this bashing about Obamacare and the Affordable Care Act. It's complete ignorance, and it's politics, and it's BS, okay? And you guys are all on your parents' insurance, okay? And maybe you're 25 years of age, 23 years of age, okay? Before the Affordable Care Act, what age did you get kicked off at?
If you were no longer a full-time student, you got kicked off. I think it was like age 22 or something like that.
Yeah, I thought it was 18, but anyway, it doesn't even matter. But
you had to be a full-time student.
You had to be a full-time student. Yeah. And then, and you know, you talked about annual limits and lifetime limits. You know, her clinical trial costs $350, almost $400. We would have blown through that annual limit, and we would have had to sell our house to pay for her cancer treatment. So, lifetime limits, same drill.
I have definitely benefited from this in the sense that I would not be alive right now because there's no way I was going to sell my house to pay for cancer treatment and have my kids be homeless.
Anyways, all right. So
anyway, so there's a cool video about cancer biology,
and how
kind
it
of
works.
Explaining how you have these mutations that happen in your DNA, and then the cells are, rifling around your body, and they eventually become cancer cells. And
then when the genes have gone bad, you have two different reasons why you get cancer. So Julie can explain that, and then
we put this graphic in because it's one of the quiz questions, and this is something that students sometimes have a little bit of trouble understanding. We have something called proto-oncogenes. When they get mutated in a cancer cell, they're called oncogenes.
I hate that terminology. What is a proto-oncogene? Proto-oncogene is just it's your normal genes for growth. Okay. So when you eat some food, okay, you release insulin, okay, and then the insulin binds to the insulin receptor, and it says, okay, time for cell division. And then there's a whole cascade of protein to say, okay, you do this, you get new beautiful cells, right? Those are normal growth genes, also called proto-oncogenes. However, they can become mutated to become an oncogene, and then they have 50, 100, 1,000-fold out of control activity compared to normal.
It's like too much gas in a car. Yep. So your proto-oncogene gets mutated, it's like too much gas in a car.
Right.
So your cells are dividing, growing, and you get a tumor. Tumor suppressor genes are genes that put the brakes on cancer cells, but then they get mutated and you have no brakes. So now your car's going really fast, your cells are growing, your cells are dividing, and there's nothing to stop them.
Why do you have cell brakes? So what happens is, remember I told you, biology of aging, okay, we need to go in there and repair the DNA. So what happens is we have the most infamous of genes that causes cancer. It's the most common mutation of all the cancers. It's called P53. And P53 says, breaks. It stops the cell from dividing, and then it tells all of its downstream partners, hey, you go in there and repair the DNA, clip it out, fix it up, and then I'll take my foot off the brakes, and you can go do what you want to do. And if the mutation is super bad, P53 says, okay, let's get rid of the cell, and it actually hits a kill switch that kills the cell, and biologists like to call that apoptosis.
So we, humans, have 2 copies of P53. Elephants, fun fact, have many dozens of copies of P53. Elephants don't get cancer.
There you go.
So if we have 2 copies, one gets mutated, you're at higher risk for cancer. Both gets mutated, you are in a world of hurt. I added new this year because I think it's so, what can we do to reduce our risk of a bad outcome? get screened. And I think it was helpful to have kind of recommendations from a reputable place like the American Cancer Society to talk about what screening should we be doing. A lot of it is based on risk in your family. So you might be high risk of colon or rectal cancer if you have certain genetic mutations, genetic conditions that are known in your family. If you had it, you'd know because a lot of people in your family would have gotten colon cancer at a young age. But then once you're in your, say 40s to 50s, it's time to start getting colonoscopies. And then once you get a colonoscopy, your doctor will say to you, okay, I went in, I looked at your colon, you were squeaky clean, there was nothing to worry about, come back in 10 years. Or maybe I found a couple polyps, they weren't a big deal.
See this little outgrowth on your colon, and it's like an array of really bad funky cells. They clip it off.
And they biopsy
and then they go send it to the lab, and the
So-
lab says not cancer or cancer.
So if you have a couple polyps, they might say, well, I want you to come back 5 years. And for me, I tend to have more polyps, and my lymphoma was actually found in my colon originally back in 2013. So I have to go every 3 years. And they've done a lot of things to make colonoscopies more comfortable. For prostate cancer, easy test, you'd get a blood test. So not a problem. I think a lot of men are like, hey, stay away from my prostate. That's very personal to me. But a blood test is easy to do.
They used to do a digital exam.
They don't do that anymore. I don't know why. Breast cancer, if you're high risk for breast cancer, if you have the BRCA gene, for example, in your family, you would know because your mom and your aunts and your sisters would all have had breast cancer before menopause. You can also get genetic counseling and genetic testing to see if you have one of these higher risk gene mutations like BRCA. But then once you're in your 40s, you're going to the gynecologist, you're getting a breast exam, you're getting an order for a mammogram every year. And you may, for example, I'm higher risk. Again, I have a lot of breast cancer in my family, and I have dense breasts, so they want me to get an MRI, alternating a breast MRI with a mammogram every other year.
A dense breast just means when they do the X-ray, that is a mammogram, they can't see through all.
So it's a little bit harder to see.
And fat is easy to see through, but if you have a lot of ducts and fibers, then you can't see through it. That's what it is.
And so a lot of people are afraid of mammograms. For me, they've always been pretty easy, and they give you this really nice robe you get to wear, and the people who do it are very nice people. So that's cool. Cervical cancer testing, you can start earlier. You can get, typically what they do now is they do a pap smear. And when they do the pap smear, they can do an HPV test. You don't need the HPV test every year. Since HPV is very, very common, some people get infected and they beat the infection and it goes away. Some people get infected and they don't beat the infection and it sticks around. And those are the people that are at higher risk for cervical cancer. So it's a good idea to get those pap smears. Again, easy test. It's easier than getting your teeth cleaned, or I don't know. I mean, there's a lot of things it's easier than. So very good test, and you want to avoid having that. Lung cancer, go back up. I'm not done. I have a special fondness for lung cancer patients because my aunt passed away from lung cancer. She was my favorite aunt. She was like a second mom to me. And my dad had lung cancer before he passed away from other causes. So if you have a family member who's a lifelong smoker and they're 50 years or older, the recommendation now is that they go in and get a yearly low-dose CT scan.
It's just a really fancy X-ray, right?
It's an easy test. You lay on the table. It takes about 15 minutes. And that's a way of finding lung cancer really early. And they can go in and clip that little nodule out. And you don't have, more advanced lung cancer. It's a lot easier to treat.
Awesome.
So I highly recommend that. It's very underutilized as a screening test right now.
All right,
so we have to get the word out. Okay.
All right, so back to module 5.
Yeah, let's talk.
All right, and then we're going to go into the discussion. Let me get there.
Go down there.
Also, you guys were doing the quiz. I've told you a million times how to do that. You can open them up 2 different windows. All right, so what we do is we have the prompt here, okay? All right, this talks all about grief, and Julie sets up alternative assignments if this is too sensitive to you, and she'll talk about it.
Yeah,
And
unfortunately and sadly for some of our students, you've had a recent loss of a close family member or a close friend, and you don't want to talk publicly about death or dying or grief, and that's okay. You can contact me, and I'll give you an alternative assignment. Sometimes people say, I'm willing to share my thoughts on this with you, professor, but I just don't want the other people to see it. And so then you could just email me your post, and I'll make sure that you get the points. But anyway, and some of you are lucky. You've never had any loss, significant loss of a family member, or a friend, or a loved one. But
you can still talk about grief. Let's say you had a really bad breakup, and you and your boyfriend and girlfriend or significant other did this, and it blew you out of the water. You know what grief is?
Yeah.
Your dog.
Losing a
cry.
pet.
I cry every time I lose a dog. And guess what? We've been together long enough. We've lost Buddy, okay, Maple, Bella. So each 12 years old.
Yeah, I had one dog that I lost that I probably cried every day for like 2 months. It was pathetic.
Which one?
But that was Maple, because she was sick for a long time before she died, and it was sad. But anyway, so losing a pet, not getting the job you wanted, having a really bad grade in a class, or a lot of times you can have something that's complicated where the person isn't gone, they haven't died, but they're not available to you either because of mental health or addiction or some sort of conflict. So you're grieving someone who's still alive, who's still around, but you don't have a relationship with them anymore.
And we put this discussion here with cancer because she went through it and I went through it with her when she got diagnosed with cancer. All right. So then you start going through. It's like you feel this pending loss, So
yeah. So I was thinking about death a lot. I was afraid, really afraid of dying, and what I did, I almost had a phobia about death. What I did is I forced myself to go study death and dying, and watch documentaries about people dying. And what I found is that it's really pretty peaceful for the people who are dying. It's less peaceful for the family members who are experiencing it and grieving. And so I felt a lot more comfortable about the process of dying.
So there's some videos that just to get a feel, like I told you.
And we focus on Elizabeth Kubler-Ross, who created this theory of the 5 stages of grieving, which is denial, anger, bargaining, despair, acceptance. That's just one theory of grief. And when you go through denial, anger, bargaining, despair, acceptance, it may not be linear. You may go through denial, anger, back to denial. So you may skip a stage and you may hop around. That's, everyone grieves in different ways. So I think it's really important, if you are going through grief, to be kind to yourself and accept, hey, this is how I'm feeling. This is what's going on with me. And you might have a family member or a friend who's reacting very differently from you. And we kind of have to be kind and compassionate with them too, because people do grieve in different ways.
So here's the prompt right here. And again, here's the disclaimer. So, address the prompt the best you can. Learn about, it's related back to what you've learned. And if you have any issues, you contact Julia. I think we're done.
I think we are done.
All right.
Thank you for watching our video. If you have any questions or problems or anything at all, reach out to us and we'll try to help.
Pura vida. And remember, every time you do a discussion post, you respond to the prompt with your own personal response to it. And then you go in and you look at 3 classmates, and you look at their perspective, because that's you learn from each other, and it's a way to get to know each other online using this asynchronous method. Okay? All right, guys. Peace. We'll see you next time.
All right. Bye.